Good afternoon. My name is Jennifer Livingston Thompson, and I am the Director of Community Engagement at Mayo Clinic Health System for the Southwest Wisconsin region, serving patients in Minnesota, Wisconsin, and Iowa. I joined Mayo Clinic Health System in June after 25 years in television news. And while new to this role, I am very familiar with this organization's commitment to health and the health of our region, and how that commitment has been on full display throughout the COVID-19 pandemic. What I have learned in my first 3 months is the amazing collaboration that happens with our exceptionally talented local providers and the singular expertise of Mayo Clinic that enables patients to receive the highest quality in-person and virtual care close to home. In fact, in its annual community benefits report, the Wisconsin Hospital Association noted that Mayo Clinic Health System in southwestern Wisconsin reinvented healthcare delivery during COVID-19 surges so it could continue safely caring for patients. Among the specifics identified by the Hospital Association were the establishment of COVID-19 testing sites, implementing virtual options for families to stay connected to hospitalized loved ones, expanding video and phone appointments, working with local health departments, and providing community education through forums like the one we are holding today. And this is actually the 11th virtual forum we've held since COVID-19 was declared a pandemic. For these forums, we've had more than 6,000 Zoom registrations and many thousands more viewing live simulcasts and program recordings. We're very grateful for your participation today as we get up to date on not one, but two viruses. And actually, it will be more than two as we talk about the flu and even polio. I am joined today by our Regional Vice President for Mayo Clinic Health System in Southwest Wisconsin, Dr. Paul Mueller, and Mayo Clinic Infectious Disease Specialist, Dr. Raj Palraj. And we're going to devote ample time to your questions during this forum. You can submit those questions using that Q&A feature at the bottom of your screen. We're going to jump right in. Earlier this week, President Biden said in an interview with 60 Minutes, the pandemic is over. But just yesterday, the Director General of the World Health Organization said this: "We have spent 2.5 years in a long, dark tunnel, and we are just beginning to glimpse the light at the end of that tunnel, but it is still a long way off." So you can see where this can be confusing for a lot of people. So Dr. Mueller, I'm going to start with you and just giving us an overview of the current state. Where do things stand right now?
Well, thank you, Jennifer, and welcome everyone to this 11th virtual forum during the COVID-19 pandemic. And I'd like to see the next slide. And as Jennifer pointed out, the Wisconsin Health Association cited us as a leading healthcare institution in how we've addressed and changed our practice related to the COVID-19 pandemic, whether it's testing and treatment, and then how we're moving forward in what's turning into more of an endemic phase. And we'll hear more from our infectious disease expert on that topic. But if you recall, the key to dealing with the pandemic is prevention, social distancing, masking, etc., how we cared for our patients who had other things other than COVID-19, rapid testing, and you need rapid testing, and Mayo Clinic had rapid testing available to our community. What that allows is to identify cases, quarantine, and then treat them rapidly. And we're doing that now, whether it's with oral drugs or monoclonal antibodies delivered intravenously, and you'll hear about that as well. Next slide. This gives you the current COVID-19 levels in various communities, and there's a variety of websites you can go to get this information, and Wisconsin Department of Health website, the Minnesota Department of Health website, other state departments of health website. The CDC has an excellent website that you can go by county to discern where things are at and what recommendations are for you regarding social distancing, masking, quarantining. What if you have symptoms? What if you're positive? What do you do? What kind of treatment should you get if you are positive, depending on the risk factors you have? And if there's one thing to know, is that it may differ according to your age and whether you have diabetes or cancer and how you're treated. And you'll hear more about that from Dr. Palraj. The other piece of this is the paramount importance of vaccination. Just about every study has shown that adverse consequences of COVID, whether it's blood clots or long COVID, death, hospitalizations, can be avoided or prevented with vaccination. But I'm not the expert on that. Right now in La Crosse County, we're at a medium level, and there are suggestions that go with that according to level. Just stay attuned to that and be careful. And while there are some higher pockets, most areas in our region are experiencing medium or low incidence at this time. This doesn't mean we're beyond the pandemic, but it's certainly better than it was before and what we've experienced over the last several years with those major surges. So I'm going to turn it over to Dr. Raj Palraj. He's been in this forum before. He's probably the most widely known infectious diseases and reassuring expert in our region. And what Jennifer didn't tell you, in La Crosse, he was a rising star under 40 last year, and for good reason. Thank you, Dr. Palraj, for being here. And we'll start out with a question: how do we further reduce the incidence of COVID-19 in our region? And what can we do to avoid another surge?
Thanks, Dr. Mueller, for the kind words, and good afternoon to everyone joining us for the community forum. First, talking about the COVID-19 and how to prevent the surge during the winter months, the most important thing that we can all do is to be up to date with the COVID-19 vaccine. I will talk more about the COVID vaccine in the later slides, but the CDC has given recommendations that everyone above the age of 12 should get a booster vaccine that contains the updated virus strains. So that's the most important thing that we can do as individuals to protect ourselves as well as our community members. Next that we can do is follow the CDC guidelines, looking at the community level prevalence of COVID and how to follow the guidelines on masking and social distancing. Please move to the previous page. So I will start my talk on the monkeypox. As you all aware, the monkeypox has been in the news for the past couple of months. Monkeypox is a very rare virus. It's caused by a virus in the same family as smallpox virus, but it is not as severe as smallpox. It was first identified in 1958 when they found the virus in a group of monkeys that was in the lab. And that's how the monkeypox name came about. But the most common animals where the virus circulates are actually rodents. So it's not the monkeys that are the primary animals where the virus circulates normally. In first human case of monkeypox was in 1970s. And over the past few decades, there have been cases in humans in several Central and West African countries, and most of them involved contact with wild rodents, African rodents. When there have been few cases of monkeypox outside the Africa, it has always been linked to an travel to the country in Africa or contact with a pet animal that is from Africa. Next slide, please. So what happened in 2022? The first case was identified in the UK in a human with monkeypox. And within few months, there have been cases worldwide, and more than 70 countries have been affected with outbreak of monkeypox. The first case of monkeypox in US was in May 2022. And in July, WHO announced that it's a public health emergency of international concern. Overall, approximately 24,500 cases have been identified within the United States. And the good news is there has been only one death so far linked to monkeypox in the US. Globally, there have been approximately 64,000 cases, and 26 cases have been identified to have died of monkeypox globally. Next page. Next slide, please. So who are the high-risk individuals to get monkeypox? What we know so far, looking at all the cases in the US and globally, the median age of a patient with monkeypox is around 35 years, and 98.2% are men or male sex at birth, and 1.8% are female at birth. And majority of cases are among gay men or bisexual men who have sexual activity within the past 3 weeks. Over the past few years, there have been few cases who have were outside the high-risk individual group who got through household contact, but still majority of cases are limited to the high-risk population of gay men or bisexual men who have man-to-man sexual activity. Next slide, please. So this slide shows that fortunately the number of cases are declining in the US. So on the left is a slide about the percent positivity rate of viral testing done. And on the right is a slide showing the number of monkeypox cases in the US. Both are declining. Next slide. So 2021, there was one individual who traveled to Nigeria who got diagnosed with monkeypox, and the patient was followed, and no other individual got infected. In July 2021, one person returning from a travel to Nigeria on two commercial flights got diagnosed with monkeypox. When CDC did the contact tracing, no other individuals on the flights got the monkeypox. In 2003, we had the largest outbreak of monkeypox in the US, and that was through contact with pet prairie dogs. And these dogs, pet dogs, before they were sold to their owners, they were housed near imported African small mammals. So the pet dogs got the infection being in the same housing as the African rodents, and then they transmitted to humans. During that outbreak, there was no human to human transmission. And since then, CDC and FDA have issued a joint importation ban on African rodents to the US. Next slide. So what are the symptoms of monkeypox? The most common symptom is rash. It can start as a pimple-like lesion, and it can evolve into a blister and then turn into a scab before healing completely. The fluid within the vesicle or the blister is filled with viruses. So those are the highly infective material. And people get transmitted when you touch the infected material, and then that's how you get infected. Some people may have flu-like symptoms before developing the rash, but some people may not get flu-like symptoms, and it is just present as a rash. So the presentation can vary from individual to individual. The lesions can be very painful and itchy, and sometimes the pain is severe enough that they need hospitalization for pain control. They may have fever, chills, swollen lymph nodes, muscle ache, headache, sometimes cough and sore throat. But rash is the most important um, key clinical finding, and the rash lesions are the main mode of transmission. Next slide. So how does it spread? So I mentioned that the vesicles and the open wounds, the fluid are filled with viruses and they are the infective material. So even though we don't know whether it's sexually transmitted, the activity of close contact during that activity makes it a high risk for transmission. Hugging, kissing, prolonged face-to-face contact, and sometimes the fluid can spill onto the fomites like towel or bedding, and if that is shared by other individuals, that can transmit the virus. The good news is the household common disinfectants are able to kill the virus. So that's the good news. And one other good news I would say is there was a recent report from Colorado where they had 300 healthcare workers who were exposed to monkeypox cases. And when they were followed for the next 21 days, none of them got secondary infections. So that's a good news. So it's not highly contagious like COVID. Next slide. So what vaccines do we have? There are two vaccines that can be used against monkeypox. The most common vaccine that is available and used in the US is the Jynneos vaccine. It's a live attenuated vaccine, but the virus in the vaccines does not multiply. So if you get the vaccine, it is not multiplying in the body, so you cannot spread it to anyone else. And it's given as 2-dose series, 4 weeks apart, and it is a primary vaccine that's used in the US. Who are getting these vaccines? The CDC has recommended for certain high-risk individuals. The first group or the post-exposure group, say someone is exposed to a person with monkeypox, a person who had a sexual activity with a person with monkeypox, or was a contact tracing as defined by the CDC or the public health. They are given the vaccines, preferably within the first 4 days or up to 14 days. That vaccine, if it's given within 4 days, can help to prevent secondary infection. And if it's given more than 4 days, it will at least slow down or reduce the severity of the illness. The second group of individuals who are eligible to get the vaccines currently are the high-risk population, especially those who have had high-risk sexual activity within the past 2 weeks. It is not recommended for the general public. I don't think it will. We will be in a position where we will be saying everybody should get the vaccine. Next slide. In May, the vaccine was released from the National Strategic Stockpile, and as of September 20, approximately 684,000 doses have been administered. Again, only for high-risk individuals as defined by the state health departments. In August, because of the limited supply of the vaccines, FDA issued that the vaccine can be injected into the skin at a smaller dose rather than subcutaneously or beneath the skin. And FDA believes that this will help to extend the available doses of vaccine and provide similar immune activity. But US has already ordered 2.5 millions of the vaccine from the manufacturer. So within the next few months, we will have plenty of supply of the vaccine if we need. Next slide. The other vaccine available is Acam 2022 vaccine. It's approved for smallpox. It can be used as an alternative. It is given as a single dose into the skin, but it requires multiple pricks using a special needle. And as a result of the vaccination, there will be a sore lesion in that area of the skin, which is called as a take. And that's how we know that the vaccine has worked. It is from a live virus in the vaccinia family. And since it's a live virus, it can multiply within the body and can spread to others. So there are certain people who should not get this live vaccines, and they are people with weak immune system, pregnancy, certain skin conditions, or who live in a household where there are people with weak immune system. And I have to say that this vaccine is not currently in use in the United States. Next slide. And how good are these vaccines? So from previous outbreaks, we know that they are 85% effective. Obviously, we don't have the effectiveness data during the current outbreak. In the animal studies and preliminary human studies, they are able to produce robust antibody levels. They are safe. The main side effects that we have identified so far is a little bit of pain and redness and itchiness in the area where the vaccine is given. And for 24 hours, they might have little fever and chills, but no significant side effects have been reported so far. Next slide. So someone has monkeypox, what treatment do we have? Treatment is mainly supportive. The good news is most people recover fully without any specific treatment within 2 to 4 weeks. So if they have pain or itchiness, we have to help them with pain control and medicines to control itching, but they do not require special treatment. Certain patients who are high risk, for example, severely ill patients in the hospital, weak immune system, pregnant women, or who have atopic dermatitis, there is an experimental investigational drug that's available that is called as Tecovirimat. It is uh, given with the help of CDC as an investigational new drug, and it inhibits the viral protein 37. It seems to reduce the symptom and the severity, but we use it very judiciously because the virus can get resistant to this drug if we use it widely. So it seems to be helpful, but we reserve it only for people who actually need it the most. Next slide. So what are the projections looking at the data so far over the past 3 months, looking at the number of cases that's declining and looking at the fact that majority of the cases are still within this high risk subpopulation. CDC believes that within the next 6 months, the outbreak can be brought under control. Obviously, uh, there are many unknowns. We have to look at what impact the vaccination has on the high risk population and their behavioral changes. So far, we haven't seen any significant outbreak in other congregate settings like daycare, schools, colleges, prisons, but we have to keep a close eye on those. And we have so far not seen a lot of asymptomatic spread, but we have to keep a close eye on that and whether the virus will mutate and evolve into something else. Again, it's a very, very low possibility, but these are all unknowns at this point. Next slide. So in summary about monkeypox, the daily cases are declining. Most of the cases are in high-risk subpopulation, and they also have a high incidence of HIV and other sexually transmitted diseases. Few household and non-sexual contact to date. So far, 27 pediatric patients have had confirmed monkeypox. Sexual activity and close skin-to-skin contact, the contact with the infectious fluid from the skin lesions appear to be the big mode of transmission. And vaccines are given for high-risk individuals now. And yes, the projection is it will be contained within the next few months, and it will remain within the high-risk subpopulation. We believe it won't spread to the general population. Next slide. This slide, we move on to the COVID-19, and these are all good slides to look at. The daily COVID cases, daily hospital admissions, and daily deaths are in the downward trend. They are, and you can see that they are below the historical peaks, and we want to keep it that way, and that's why vaccinations are very, very important. Next page. So CDC has a very good website that shows what are the current variants of COVID-19 that's circulating. And as you can see in the first week of September, majority of COVID-19 strains were BA.5 and a small proportion was BA.4.6. And these two new variants were added to the Pfizer and Moderna vaccines. So the new bivalent COVID booster shots contain these two new variants. And that's why we want everyone to get this updated booster vaccine. What we know about these variants, they are much more transmissible than the previous variants, but fortunately they seem to cause less severe disease. We have seen lower hospitalizations. But the other impact, such as long COVID, is always there, and that's why we need to prevent infection, even though it's less severe. Next slide. So the booster vaccine contains it contains the original strains as well as the two variants that's circulating now. And the bivalent Pfizer or bivalent Moderna are recommended for everyone to be up to date. Pfizer can be given for anyone 12 years or older. The updated Moderna can be given for anyone 18 months or older. It can be given 2 months after the most recent shot of COVID-19, whether it's a primary or booster shot. And it can be given on the same visit as your flu shot. And since flu season is coming, it's important that we encourage everyone to get flu shot and the updated booster shot on the same visit. Next page. So what treatment options we have? We have had very good success with the oral Paxlovid. Oral Paxlovid is the treatment that can be given for high-risk patients in the outpatient setting, and it has been very successful in preventing hospitalization. And you might have seen in the news that a small proportion of patients who receive Paxlovid have rebound symptoms, and it's still a small percentage, and usually it's less severe, and we typically give another course of Paxlovid and they do well. Molnupiravir is not that effective, so we haven't used it much. Baptolovi Map is a monoclonal antibody infusion. So if patient in the outpatient setting, they have a lot of drug-drug interactions with the Paxlovid, or if they have a weak immune system, then we give the monoclonal antibody infusion, Baptolovi Map, and the data shows that it's very effective in preventing hospitalization. And oral baricitinib is an anti-inflammatory drug that we used to use in the intensive care unit when patients are very sick with COVID. Fortunately, we haven't used oral baricitinib that frequently. That's because we haven't seen a lot of severe cases of COVID. And that's the result of the COVID vaccination and the social distancing. And we need to continue that. Next slide. So in summary, BA5 and BA4.6 are, are the predominant strains now. And these two new strains are included in the updated Pfizer and Moderna. Get the flu vaccine at the same time as the COVID vaccine. Monkeypox is declining. It remains within the high risk subpopulation. I don't think it will spread to the general population, but we have to keep a close eye. And that's the prediction from the CDC as well. Next slide. Thank you. And I'm happy to answer any questions now.
Well, thank you, Dr. Palraj, and please submit your questions. And we actually have some that we get frequently asked, and I'd like to just go with a couple questions about COVID. I'm an internal medicine doctor, and this week alone, I've had a number of patients who've been vaccinated. They might have a little sore throat or flu-like symptoms. They test, they're positive. And I've prescribed Paxlovid, and I've prescribed monoclonal antibody. For some of my patients, I prescribed Evusheld to prevent infection if they have cancer. But a common question that comes up in that setting is, I just had COVID, I feel fine. When can I get the new bivalent vaccine? Or I just am getting treated with Paxlovid, or I just finished it. When can I get the new bivalent vaccine? Or I just got monoclonal antibody. When can I get the new the really common question we're dealing with right now, because out there, and I've seen what the CDC says, but I want to hear it from you, Dr. Palraj.
Yeah,
It's widely variable. You should wait 2 months, 3 months, whatever. So could you tell us about that?
yes, that's a very good question and a common question. I think the concrete answer is available for people who receive the monoclonal antibodies, the Baptolovi Map, and the recommendation is to wait for at least 90 days. And that's because the antibodies will stay in the system for that period of time. And if you give a vaccine, it may not produce the immune response that we are hoping for. So that's the most important factor. For people who received Paxlovid or who didn't get any treatment and they recovered on their own, it's better to get the COVID booster shot as soon as possible. It is true that the actual infection will provide some amount of natural immunity for further infection, but we don't know how much. What we know is if you get a booster dose, the protection is significantly higher than the natural infection. So for people who get the monoclonal antibodies, I would wait for 90 days. For people who got Paxlovid or they recovered on their own, they can get it once they recover from the symptoms.
And one follow-up question, and I'll turn over to Jennifer, is I often get asked, should I just take Paxlovid to prevent future infections, or can I do that instead of a vaccine? Does that make sense at all?
As infectious disease experts or like in specialty, we want to avoid like chronic prophylaxis because the virus is very intelligent. It constantly mutates and it can develop resistance. And we talked about the tecovirimat for the monkeypox. That's the same concern. If we use it more widely, it may not work. And in the field of infectious disease, the development of resistance is a big issue. and it applies to antibiotics as well. We don't like to give antibiotics like more than what is needed. Uh, we do that in HIV treatment as well. We worry about development of resistance a lot. So we have to use these antiviral drugs judiciously. We need to use it when we need to use it and for people who benefit the most.
Thank you.
Dr. Palraj, thank you, first of all, for all of the information. Every time I would think of a question, you would answer it with your next slide. And so you do a really wonderful job of giving an overview of where we are at with both of these situations. I want to invite those who are listening. There is a Q&A button at the bottom of your screen. If you have a question that you would like to submit to ask either Dr. Mueller or Dr. Palraj, we invite you to do that. We have been getting a few questions in, and I'll just start asking a few of them. One of them, does my childhood smallpox vaccine from the 1970s protect me from monkeypox?
That's a very good question. And there is a possibility that the childhood vaccine for smallpox will provide cross immunity or protection against monkeypox, but we don't know how much. But theoretically, monkeypox and smallpox are similar, and there will be some protection against the monkeypox.
Another question here, what do you feel will be worse this winter, flu, COVID, or something else?
That's a an impossible question to answer. I think we have been wrong many times during the COVID pandemic, so we have to be humble. What we can kind of see the trend is we know from the experience of flu season in Australia that the number of cases in Australia was almost 5 times or 3 times the highest number of flu cases in the past 5 years. And people have many theories. One, we are reducing the number of times where we use masking. And since the flu season was mild during the last year, the immunity level may have gone down. So there is a projection that the number of flu cases this year will be higher than last year. So that's one projection. But the COVID, I think it will remain under control as long as everyone gets a booster shot. Monkeypox, I'm projecting that it will continue to decline and agree with the CDC projection that it will remain within the high risk subpopulation and it won't spread widely.
We have a question about long haul COVID symptoms, but I think before we address the question, it would be really good to get an update on what are we seeing as far as long-term symptoms of COVID, the impacts. Are there any new complications that have come up? And I imagine that the effects are still being uncovered as time goes on.
Yes, there are long COVID is a syndrome that we see in 5 to 10% of patients with COVID. People commonly feel very fatigued, lack of energy, cognitive impairment, or what is called as brain fog. Sometimes they can have a headache, and we still don't know a lot about what are the mechanisms by which people experience long COVID and what are the treatment options. So there are many clinics, including long COVID clinic at Mayo Clinic Rochester, who are actively studying patients and how to help them. But we still don't know a lot.
So the question from one of our listeners about long haul COVID is it okay to get the booster, or should you get the booster as soon as possible if you have long haul symptoms?
Yes, absolutely. So what we know is the long COVID is not due to active viral replication. And we have a similar syndrome from other infections as well. Even after the pathogen is completely gone from the body still feels that it's fighting the infection. So for people with long COVID, we don't see the virus still actively multiplying and causing disease progress. So I would recommend them to get the COVID booster shot to prevent another infection, which can worsen the long COVID symptoms.
What is the current recommendation concerning masks? And Dr. Mueller, I wonder if you could give an update. I noticed that, masks are still required inside Mayo Clinic Health System in La Crosse. I know that there are some areas that are outside of where there are patients being served that masks are not as utilized. What is the recommendation for the general public and for the healthcare systems?
Yeah, I'll take a stab at that and let Dr. Palraj comment on it. But basically, in clinical areas where we see patients, masking is required. We have relaxed the restriction on eyeglasses. So if you come to our sites, you'll see our clinicians, nurses, and others wearing masks, but not the protective lenses. Now, some continue to choose to do that. And of course, we don't object to that at all. Part of it has to do with the fact that people who come to our sites are sick, have symptoms, they may or may not have COVID. So if there's ever a place you're going to encounter people who carry the virus, it's probably in a healthcare setting. In my personal practice in my life, and when I see patients and I'm in clinical areas, I wear a mask. In our office settings outside of clinical areas, we can remove the mask, but we recommend social distancing, hand hygiene, and being careful. When I'm out in the public, I take a look at what's the spread. So if it gets into that medium high level, you want to be careful. And then going through places like airports, I was actually in the Minneapolis airport this past weekend. It was pretty crowded and very few people had masks on. But that's precisely the type of place where infectious diseases are spread because people are coming from all over the place. The other thing to bear in mind about masks, and I think we're learning this as a society, during the COVID pandemic, we had a marked reduction in influenza cases because people were social distancing, washing their hands, and wearing masks. So there is some utility to it. We're being less stringent about it because of the epidemiology of the disease. And then finally, vaccines work. They don't even not only prevent hospitalization and death, and the data are very clear about that, they also prevent other outcomes like long COVID. And there's a really interesting emerging amount of evidence how they prevent blood clots, which are associated with COVID disease. And finally, I want to say this, on Monday, I received the bivalent vaccine. We can give it to you along with the influenza vaccine, and we have both vaccines available here in La Crosse.
Dr. Palraj, you briefly mentioned a time frame for which you can get the most recent booster, but one of the questions has come in that if I've had COVID recently within the last few weeks, how long do I have to wait before I get that booster?
If you have improved from your symptoms and you are outside the 10-day window, we typically ask you to isolate. You can get the booster shot. Once the symptoms are better, you can come to the clinic and get both the COVID and the flu shot.
All right, thank you for that.
Can I jump in for their question on that?
Absolutely, Dr. Mueller.
So now what I'm hearing also from patients, Dr. Palraj, should we time the flu vaccine because of when that usually occurs? Some people, we're seeing reports, I think I saw one in the Washington Post saying, get your bivalent now and maybe wait a month for your influenza vaccine based on the timing, or do you recommend getting it together? Some people would like to just get it over with. Some only like to get one shot at a time, but is there any science behind separating the two?
No, there is no science that tells us that you have to separate the vaccines. The reason why we want both vaccines to be given at the same time is that it's more convenient and it will encourage more people to get the both vaccines, and in that way more people will be covered. Giving two vaccines at the same time, it doesn't have a big impact on the antibody level in the patient. The other question is, should you wait and time the flu season? Uh, like the stock market, it's never good to try to time the flu season. And we know that in Australia, the flu season it started much earlier compared to the previous years. So one of the projections is the flu season may come sooner here in the US this year. So I would recommend to get both the shots as soon as possible, and it can be given on the same day.
Thank you.
I'm curious if you take a look at last year's trends and earlier this year's trends with COVID and numbers increasing after certain events that will happen every year, back to school, family gatherings at the holidays, and predict whether or not you foresee that happening yearly in the future again.
Yes, I think the question is whether the COVID will stay with us and will it be in every winter season like a flu season? The project, I think that's where we are going. I think we anticipate that we will be getting a COVID shot in addition to the flu shot for that at least the next few seasons.
And do you anticipate more specifically, last year after holiday gatherings in December, we saw a big spike in January. Do you anticipate that that will be a trend that may happen again this year? Or are we encouraging people to be safe again around those large gatherings that take place?
I anticipate that there will be an increase in the number of cases, but it won't be as high or like a surge that we saw last year, because we have a huge number of population who are vaccinated. They have a basic level of immunity, and hopefully with all the bivalent vaccination, we might see a small rise in numbers, but not like last year. And in terms of recommendations for social gathering, I agree with Dr. Mueller. I think we have to use common sense precautions. As an individual, get vaccinated and use the guidelines when to be cautious about mask and when we can be without mask.
I have a question about the cost of covering COVID. So since the beginning of the COVID-19 pandemic, the federal government has covered the majority of COVID-19 testing and vaccination and treatments. And it appears that there is a shift happening there in that coverage. Can you give us some information about that and what the future looks like as far as those things being covered?
I believe the federal government has transitioned the payment aspect to the private insurances for the COVID treatment. And I think that's a natural evolution. We are no longer in the COVID emergency situation as a nation. And that's probably why the federal government has transitioned the payment models to the routine private insurances.
We have a question. How much is monkeypox a behavioral pandemic versus a gender pandemic? You showed those statistics earlier, 97% male. Can you speak to that question?
I think it's too early to kind of know why the outbreak is kind of highly concentrated in one subpopulation and whether it will spread. So what we know so far is more than 98% are men who have sexual activity with men. But more than that, I don't think we can specifically point towards one behavior or gender-based theory.
Yeah, one of the things about the slide that you presented that I had a question about, it seems like you're actually seeing an increase in the number of straight men, to use that term, who have monkeypox. And it reminds me, when I was in training in the 80s, we saw that same phenomenon in HIV. And so it'll get into the population where men and women together, close proximity. And that's the concern you have about college campuses, dorms, daycare, et cetera, that if it gets out of that into those settings, you could have a problem. And that's why monitoring is important.
How does it work, Dr. Mueller, when something like monkeypox comes up? I mean, there were a couple of students that were tested at UWL. It came back negative at the beginning of the year that they were tested for monkeypox. But how does the hospital prepare for the possibility of something like this, an unusual case, in case it does come through their doors?
Well, it's one of the reasons we rely on colleagues like Dr. Palraj to keep us alert to that. We have infection and prevention and control services, and I get email updates on any outbreaks of reportable communicable diseases that occur in our community, and then our teams are on top of it. And they inform our team members on what you should look for, how you should protect the staff, what you should do with a patient you suspect of having that disease, how you should test for it, and the reporting process, because case identification is critically important to prevent the spread of these diseases and for the proper treatment. Raj, do you want to comment on that further?
Yeah, I would add that being part of Mayo Midwest enterprise, we have the expertise of Mayo Rochester as well to help us. In more than the monkeypox, we have a standard protocol for all high consequence infectious diseases. So we don't have to reinvent the wheel for one COVID or monkeypox. We have a plan in place for anything that can come into our doors. And I think that's one of the nice things that happened during the COVID, that all the protocols were fine-tuned and streamlined.
Well, that brings up a great transition into, as if we need another virus to be concerned about, but polio has actually been in the news recently. Can you give us an update on what's going on there, Dr. Palraj?
Yeah, I think polio cases have been identified mainly in New York, some of the counties, and polio was detected in the waste water as well. So that tells us that the virus has been circulating in the community. And cases have been identified mainly in individuals who have not been vaccinated with polio. And most of us in the US have had vaccinations. Polio vaccine is part of the childhood vaccination. It is given as 4 doses. So almost all of us have been vaccinated with polio. So, and the polio vaccine is very, very effective. So if you're vaccinated for polio, there is no need for concern. And for people who are unvaccinated, they can get the 3-dose vaccines again. For adults, it's 3 doses. For kids, it's 4 doses.
And if people have concerns about polio vaccine and whether it's a trivial illness, I always think about the fact that if you've been to St. Mary's Hospital in Rochester, there's the Domitillo building there, and it's an enormous building, and it was built as a polio ward for iron lungs for that purpose. And when the vaccine was introduced, it was no longer needed for that purpose.
Well, I want to take the opportunity to let people know we have a flu shot clinic coming up at Mayo Clinic Health System, a public flu shot clinic that will begin on October 17th, that will run from 8 a.m. to 5:30 p.m. Monday through Friday, concluding November 11th. But that brings up a question about flu shots and who should get them. What are the ages? Are there any individuals that should not get the flu shot?
Flu shot, everyone age 6 months and older should get a flu shot. There is almost no one where the flu shot is contraindicated. If you have severe anaphylactic reactions to previous flu shot, then that might be a contraindication, but I would encourage everyone to discuss with their healthcare team to kind of identify those contraindications. But it's universally recommended for everyone 6 months or older. For what's new this season is for people who are 65 years or older, the recommendation is for high dose vaccines. So there are 4 vaccines which are preferred for people who are older than 65. Again, the healthcare team will be able to recommend the higher dose vaccine if you need it.
While we're on that topic, pneumococcal vaccine, tetanus, diphtheria, pertussis, should we give those at the same time if you haven't had them?
Yes, so the inactivated vaccines can be given at the same time with no effect on the amount of antibody levels. It can be given at the same time.
You'll have a sore arm, but
Yeah.
in my case, some ibuprofen took care of that.
We're nearing the top of the hour. I have a really interesting question here for animal lovers. So you started out the conversation with monkeypox, talking about it being discovered in monkeys, but most likely coming from rodents. The question is, can dogs be infected and cats by monkeypox? And is there a concern there?
So it can be transmitted to pets, including dogs and cats. And CDC has given some recommendations. So if someone has monkeypox and they have pets at home, if their pets have not been previously exposed to the virus, it's better that the pets are given to friends or family for the next 21 days till all the lesions kind of resolve. And then you clean your household before bringing in the pets. So in that way, you're not transmitting the virus to your pets. And if the pets are exposed to monkeypox, they have to be monitored for the next 21 days, just like how we monitor humans exposed to monkeypox to make sure that they don't get the lesions and they are isolated during that period. No need to kind of euthanize the pets. There is no concern. We just have to isolate them and monitor.
I think we'll have this last question of the day here, which is, so I have a whole bunch of take-home tests still in my closet. A few of them have expired. Do I need to, one, throw those away? And are we still encouraging the use of take-home tests for folks who may think they have COVID?
Yes, home tests are still very good. If you have the symptoms, that's one of the important things in preventing a surge. So we talked about masking, we talked about COVID boosters, and the third important thing is if you have symptoms, get tested, isolate, and prevent further transmission. If it's expired, I think we can't speak for their usefulness.
And I want to jump in. What I'm finding in my own practice is patients are calling in with their positive home kit. So that's now more prevalent. And then we have a system in place to identify those who would benefit from treatment. And the real important thing is to test immediately rather than waiting, because the timing of the ineffectiveness of the treatment is the effectiveness of treatment is based on when you treat after your symptoms develop and when you get the pot. If you wait a week to tell us or take the test, you're now in a period where treatment may or may not be as effective. I do have one more question for Raj, if you don't mind asking, because a lot of the people who live in our region are immunocompromised. They might be on prednisone for asthma, or they're taking treatment for rheumatoid arthritis or cancer. Aside from vaccine, what can we do to help prevent disease? There was that medicine, I mentioned it earlier, Evusheld, but does that work anymore, or is that changing, or what do we do for those folks?
Evusheld is still effective against the new variants. So for people who qualify because of their immunocompromised state, where we believe that they may not respond to the vaccine as well as person with good immunity, I would recommend to get the Evusheld.
They should get the vaccine and then get the Evusheld a couple of weeks later.
Yes, to have protection from both. Yes.
You heard it from the expert for those of you listening.
Well, I would like to thank both of you, Dr. Paul Mueller and Dr. Raj Palraj, for your time, your expertise today. This was my first one, and I found it very, very interesting. And the knowledge you both share is really great for everyone. I also want to acknowledge the Mayo and Mayo Clinic Health System staff who work behind the scenes to make this forum possible. And I certainly wish to thank all of you out there for joining us today. As always, we welcome your feedback and your suggestions on topics for future forums, and we hope that you have a great afternoon and a wonderful weekend.
Thank you.